Hello and welcome to Chapter 10 in Alternate Care Systems. We are covering long-term care and we're going to start in our slides and in the textbook on page 354, moving down to slide number 6 to start our introduction to settings. At the top of 354 you have a little table there talking about 3 different settings in the long-term care arena. Freestanding nursing facility, which is going to include your nursing homes, your nursing facilities, and your long-term care facilities. We actually call those LTACs. And then we have our freestanding skilled nursing facility, which you'll hear called SNF, or skilled nursing units. And then we have our acute care hospitals. They can have designated areas or attached wings, or it can be a separate structure on the hospital campus that's licensed for skilled nursing care. All right, so dropping down into the text. Long-term care typically describes the care of frail, institutionalized elderly people and those who are permanent residents of a nursing facility. Dropping down to about midway on that page. As stated in federal regulations, the term nursing facility is defined as a facility that is qualified for reimbursement under the Medicaid program. A skilled nursing facility meets the requirements for reimbursement under Medicare. So nursing facilities are paid for by Medicaid, and your skilled nursing facility or SNFs, they are reimbursed under Medicare. So nursing facility, Medicaid, skilled nursing facility, Medicare. All right, let's drop down into our types of patients or residents. In long-term care setting, the term patient is often replaced with resident because the person receiving care is not only a recipient of nursing care, but in many cases also is residing in the facility permanently. The nursing facility becomes the home or place of residence, and as such, the facility is responsible for providing quality of care as well as high quality of life under long-term care regulations. So let's drop down into the section labeled Permanent Residents Receiving Non-Skilled Care. These residents are distinguished by their need for general oversight and supervision in performing their ADLs, which is your activities of daily living, those things like bathing, eating, dressing. However, their needs generally can be met without the direct care or services of a licensed professional on a 24-hour basis. Although a licensed practical nurse or registered nurse supervises their general care under the direction of an attending physician, their immediate care needs, such as injections, intravenous therapy, parenteral feeding, or skilled wound care, do not involve direct skilled treatment on a daily basis. From a level of care perspective, these residents require more care than those in residential, boarding, or assisted living environment, either because of the cognitive impairment or physical incapacity. For example, these residents, either because of physical or cognitive impairment, could not negotiate their way to safety in an emergency. Their daily care needs, however, do not require continual intervention by a licensed nurse or other skilled health professional. Next section of types of patients is permanent residents special care. So the special care unit often is a distinct service within a long-term care facility. For example, some of these units are designed to care specifically for Alzheimer's patients. They benefit from a physical environment that's quiet, home-like, and adapted to their specific cognitive impairment. The physical separation of this unit assures that residents are afforded the opportunity to move throughout the area without fear of wandering off the property. Then we have permanent residents receiving skilled care. In contrast to the permanent residents who do not receive daily skilled care, permanent residents requiring skilled care receive services from one or more licensed professionals on a frequent and often daily basis. Typically, these residents have received as much benefit from rehab services as can be reasonably expected, and their improvement or progression has plateaued. As a result, their potential to be discharged is not good. Types of care include the need for continuous tube feeding, long-term ventilator care, complex wound care, and/or aggregate combination of nursing and restorative professionals to meet the daily care needs of feeding, performing ADLs, and maintaining the highest functional level for as long as possible. Often the term heavy care is used to describe the care needs of these residents because of the intensity of their dependence on the staff for mobility, toileting, bathing, eating, and performing all ADLs. Their care can be described as more of custodial in nature. Then we have our short-term patients. A short-term patient is in a long-term care facility generally is considered as one whose length of stay is less than 100 days, and in the traditional healthcare sense would be regarded as a patient because the intent is to ultimately discharge the patient to a more independent level of care. In some long-term care facilities, the distinct unit in which these patients are found is categorized as a subacute care unit, where patients are provided with a higher level of care than that associated with traditional skilled nursing setting. And then our last type of patient or resident is respite. Respite care involves a short stay for the purpose of providing relief or respite to the primary caregivers of frail elderly people who cannot live in an independent environment and do not require the intensity of services and supervision required for the traditional long-term care facility. The period of respite care may range anywhere from overnight to several weeks, depending on the caregiver's needs. In respite care admissions, a long-term care facility provides meals and general supervision to assure that the necessary medications are administered and also provides a safe environment for the respite residents, with opportunities for socialization and no need for active care intervention. All right, so moving on to our types of caregivers. As in previous chapters, we're going to start off with our physicians. So doctors of medicine and osteopathy are responsible for overall medical supervision in the long-term care facility. However, their physical presence in the nursing facility generally is limited. Frequency of visits to a long-term care resident can range from once a month to once a year, depending on the level of care the resident requires. In some instances, the physician does not actually visit the nursing facility, but instead requires that the resident be transported to his or her office for necessary medical exams. Therefore, the majority of communication with the physician is done through the nursing staff via telephone rather than face-to-face encounters with the physician. Then we have our advanced practice clinicians. These are your nurse practitioners, clinical nurse specialists, and physician assistants that work with physicians to care for their patients who reside in long-term care facilities. Particularly in rural settings, the availability of advanced practice clinicians enables more contact with the resident than if only a physician were making visits to the nursing facility. Then we have registered nurses. They are the primary coordinators of daily care within the long-term care facility. Because physicians ordinarily do not visit residents daily in most long-term care settings, care is nursing-driven. In most regulatory environments, the director of nursing is required to be a licensed registered nurse. Depending on the number of beds, the facility will employ additional registered nurses for supervisory positions or as charge nurses on specific units. Then we have our licensed practical nurses. Licensed practical nurses are the most predominant caregivers among the licensed professionals in the long-term care nursing facility setting. Their responsibilities range from administering medications, tube feedings, and treatments to being in charge of a nursing division and serving in a supervisory capacity within the nursing department. Nursing assistants are our next set of caregivers, and they comprise the bulk of the nursing department in a long-term care nursing facility. They are non-licensed staff members who have completed a basic training course for providing daily care needs to geriatric patients, including basic skills in bathing, transfer training, lifting, range of motion, and related support services that would be provided under the general supervision of a licensed nurse. In some facilities, a distinction is made for nursing assistants who strictly provide restorative therapy. They are called restorative aides or rehabilitation aides. With additional training from licensed therapists, the restorative or rehabilitation aides have the responsibility for providing maintenance services to residents after skilled rehabilitation has been discontinued. The restorative therapy is intended to maintain the level of functioning that has been achieved from the skilled therapy and to prevent further functional decline. Then we have certified medication technicians. In some states, a certified medication technician is a distinct type of caregiver in the long-term care setting, provided for in the state's long-term care regulations. Requirements for this position typically include a minimum of nursing assistant training with an additional course in medication administration. Then we have social services. Providing medically related social services to residents is assigned to the department that typically is described as social services in the long-term care setting. Depending on the size of the facility, this department may or may not be staffed with a credentialed social worker. Federal long-term care regulations require that a facility with more than 120 beds employ a full-time social worker or a person with qualifications outlined in the federal requirements. And then we have our activities or therapeutic recreation. Although therapeutic recreation is not a direct care service in the same category as administration of a treatment or a medication, providing stimulating activities or therapeutic recreation services is extremely important in the long-term care setting. In most long-term care facilities, a licensed or credentialed individual does not necessarily direct the activity program. Licensing of activity professionals other than recreational therapists is not universal in each state. Federal regulations provide several alternative options as qualifications for an activity professional, including 2 years of direct experience in a patient activities program in a healthcare setting and/or completion of a training program approved by the state agency. Dropping down to the middle of that next paragraph. The types of activity programs within the scope of the typical long-term care facility include planning and providing for outings, such as shopping and recreational activities off the premises of the facility, planning and providing supplies and materials for independent in-room activities, establishing small group programs such as reminiscence therapy for residents with cognitive impairments, conducting in-room, one-on-one activities such as music therapy and tactile stimulation for room-bound and unresponsive residents, and planning and conducting facility-wide social events for residents and their families. And then we have some different independent contractors. In long-term care facility, most of the ancillary services and many of the professional services are provided through independent contracts with outside resources, such as those of laboratory, radiology, pharmacy, and rehabilitation, including physical, occupational, speech, and respiratory therapy services. As independent contractors, these providers are not employees of the facility and usually are not present physically within the facility on a full-time basis. All right, so again, be sure to read through that section for your independent contractors. Again, those are your lab and radiology services, your rehab services, respiratory therapy, registered dietitians, and our registered pharmacist. All right, so we're going to move over to page 362 and talk about regulatory issues. So the long-term care industry is one of the most, if not the most, highly regulated industries in the U.S. In addition to federal regulations for long-term care facilities participating in Medicare and Medicaid, each state has separate licensure laws applying to long-term care facilities. In the case of overlapping or conflicting laws, the facility is obligated to abide by the more stringent of the two laws. So whichever law is more strict is the one the facility has to go with. The standard survey is unannounced and is conducted at least every 15 months. The two general survey outcomes are substantial compliance and substandard quality of care. Substantial compliance means that any deficiencies the surveyors find are deemed to be of minimal potential for harm to the residents. Substandard quality of care means that surveyors find one or more deficiencies that constitute either immediate jeopardy to the resident health or safety, a pattern of widespread actual harm that is not immediate jeopardy, or a widespread potential for more than minimal harm but less than immediate jeopardy with no actual harm. Results of all surveys are accessible to the public, with federal regulations requiring that the most recent survey be posted in a public area of the facility for easy access by residents, family members, and the general public. So dropping down to the paragraph starting with in 1995, federal enforcement regulations were implemented by the Healthcare Financing Administration, which used to be called HCFA, which is now CMS, outlines remedies including civil money penalties of up to $10,000 per day for findings of substantial noncompliance and substandard quality of care. In addition to federal enforcement regulations, individual states may pass legislation that also gives the state agencies authority for fines and civil money penalties. Therefore, findings of substandard quality during a facility survey can result in a civil money penalties from both the federal and the state licensing agency. All right, so let's drop down to state licensure. If a long-term care facility does not participate in the Medicare or Medicaid program, federal regulations do not apply, and the facility is subject only to the state licensure requirements. The respective state legislative bodies pass these requirements, and consequently, the 50 states vary considerably in the scope of issues promulgated in their long-term care requirements. And then lastly, let's talk about Joint Commission. The number of long-term care facilities seeking accreditation from Joint Commission is relatively insignificant. There is no clear advantage for a long-term care facility in seeking Joint Commission accreditation, unless it is required as a part of an overall hospital accreditation for hospital-owned or operated long-term care facilities. Joint Commission has sought deemed status from the Centers of Medicare and Medicaid Services that would present long-term care facilities with the option of choosing between the current survey system by state and federal agencies or applying for Joint Commission long-term care accreditation. In this writing, or at this writing, the options are limited and deemed status for long-term care is approved in only some states. So there's really no true advantage for a long-term care facility going the Joint Commission route. All right, so let's drop down to our documentation issues. That's going to start on slide 12 with our federal requirements. But we're going to talk a little bit about this documentation paragraph on 364. Documentation in the resident's record has tremendous significance for the nursing facility. Documentation is vital in evaluating how a facility has contributed to and/or affected the quality of care and quality of life of the individual residents, strongly linking documentation with regulatory compliance. In addition, accuracy and appropriateness of documentation affects facility reimbursement by Medicare, Medicaid, and commercial insurance. Finally, as litigation involving negligence for poor outcomes of care becomes more pervasive in the long-term care industry, proper documentation can be crucial in defending a provider against a wrongful claim for failure to provide quality of care and services. All right, so let's drop down to federal requirements. So the quality of documentation is highly significant in the federal survey process, known as the Quality Indicator Survey, or QIS, in that the resident record is used as a means of validating positive and negative care outcomes both in the annual survey and in the complaint investigations. Survey procedures for the federal long-term care survey process include record review under Task 4, Stage 1, Admission Sample Review, and Census Sample Review, where the record is used along with observations and interviews to identify resident-centered outcome and process indicators called Quality of Care Indicators, or QCIs. When compared to national norm, QCI's focus is on more detailed quality investigation during Stage 2 of the survey. All right, so let's talk about the Comprehensive Resident Assessment and the Resident Assessment Instrument. Remember this from health records, the RAI. The Comprehensive Resident Assessment is the primary vehicle for evaluating care outcomes in the federal long-term care survey process. It includes at least the following information. Number 1, medically defined conditions and prior medical history. Number 2, medical status measurement. Number 3, physical and mental functional status. Number 4, sensory and physical impairments. Number 5, nutritional status and requirements. Number 6, special treatments or procedures. Number 7, mental and psychosocial status. Number 8, discharge potential. Number 9, dental conditions. 10, activities potential. 11, rehabilitation potential. 12, cognitive status. And 13, drug therapy. Comprehensive resident assessment refers not only to the actual resident assessment document, but also to the federally mandated resident assessment instrument, the RAI. The RAI consists of 3 basic components: the minimum data set, or the MDS, the care area assessment, which is our CAA process, and the formally resident assessment protocol, or the RAPS, and the utilization guidelines as specified in the resident assessment instrument manual. All right, dropping down to the bottom, we're going to talk about care area triggers, which is part of the care area assessment, the CAA resources, and the CAA summary. So components of the CAA process include the care area triggers, CAA resources, and the care area assessment. The CAA process provides structure for assessing social, medical, and psychological problems by providing a systematic method for reviewing key components of the MDS and directing caregivers to evaluate causes, interrelationships, and particular strengths that affect the development of the care plan. A key element of this process involves the care area triggers, specific resident responses for one or a combination of MDS elements. The triggers identify residents who have or are at risk for developing specific functional problems and require further assessment. So as of this writing, there are 20 care area triggers. 1, delirium. 2, cognitive loss, dementia. 3, visual function. 4, communication. 5, ADL, functional rehabilitation potential. 6, urinary incontinence and indwelling catheter, and so on. So you have the rest of this list on 366. Based on the resident data entered on the MDS, care areas may or may not be triggered. If a care area is triggered, this indicates a potential need to address the issue in the care plan. At this point, the interdisciplinary team can use the utilization guidelines to evaluate the problem and determine whether to continue a care plan for it. Our CAA resources offer a list of resources to consult in performing the assessment of the triggered care area. The interdisciplinary team must document the outcome of the assessment process for the specific care area and the decision regarding care planning for a given problem or need. The Care Area Assessment Summary, the CAA Summary, which was formerly the RAP Summary, form is used to document the location within the resident's record where the assessment information may be found. Surveyors then use the CAA summary to locate pertinent assessment information within the record, to evaluate whether nursing facility staff members have properly utilized the MDS information to assess and plan care for avoidable negative outcomes, and to recognize resident strengths in the development of the comprehensive care plan. And you see in Figure 10.1 on page 367 a summary, an example of a care area assessment summary. All right, we're going to skip over to the care plan section on page 368. The care plan content and its use are linked to the comprehensive assessment in the Federal Long-Term Care Survey process. Depending on the individual state licensure regulations, additional emphasis may be placed on the care plan documentation. However, this varies from state to state. In some states, care plans are not required specifically for residents who are not in Medicare or Medicaid certified beds. All right, so dropping down, specific documentation guidelines for the comprehensive care plan include the following items. Our first bullet point says, measurable objectives and timetables to meet medical, nursing, and mental and psychosocial needs that are identified in the comprehensive assessment. The second one, description of the services that are to be furnished to attain or maintain the resident's highest practicable physical, mental, and psychosocial well-being. And lastly, the description of services that otherwise would be required but are not provided because of the resident's exercise of rights, including the right to refuse treatment. All right, dropping down to this last paragraph on this page. The care plan is viewed as the focal point for communicating significant care findings, resident preferences, and goals for the individual long-term care resident. For that reason, a well-documented care plan should reflect areas of concern identified from the comprehensive assessment and an individualized view of the resident, such that it introduces the resident to each caregiver on the interdisciplinary team, from the nursing assistant on each tour of duty to the licensed therapist and physicians who care for the resident on a less frequent basis. Consequently, standardized care plans that do not reflect individualization of care routines based on specific resident preferences, strengths, and care priorities are not regarded as individualized or resident-specific. From the perspective of a long-term care survey, individualization of care information is the single most important content characteristic of a care plan in the long-term care setting. So care plans have to be individualized to each resident. All right, moving over to discharge and transfer on page 370. In the closed record review, documentation is evaluated with reference to the circumstances surrounding the transfer and/or discharge of the resident from the facility. Emphasis is placed on whether the federal regulations were followed concerning involuntary transfer or discharge of a resident to another healthcare facility. Federal regulations outline specific circumstances in which a facility may transfer or discharge a resident involuntarily, and proper documentation is critical in demonstrating compliance with these requirements. Number 1, the transfer or discharge is necessary for the resident's welfare, and the resident's needs cannot be met in the facility. Number 2, the transfer or discharge is appropriate because the resident's health has improved sufficiently so the resident no longer needs the services provided by the facility. Number 3, the safety of individuals in the facility is endangered. Number 4, the health of individuals in the facility would otherwise be endangered. And number 5, the resident has failed, after reasonable and appropriate notice, to pay for a stay at the facility. For a resident who becomes eligible for Medicaid after admission to a nursing facility, the nursing facility may bill a resident for only those charges allowable under Medicaid. All right, moving on to residents' rights at the bottom of page 370. Resident rights represent a major focus in the long-term care setting, and documentation often becomes crucial in the evaluation of potential resident rights issues and whether a facility has acknowledged and recognized the rights of residents properly in the provision of care and services. Documentation affects the evaluation of compliance with resident rights requirements in a variety of ways. In addition to providing each resident or resident's legal representative with a written explanation of his or her basic rights under state and federal law, ongoing documentation of care preferences and explanations for various care outcomes become essential in determining compliance with a resident's rights requirement. For example, if a resident has a certain diet order, such as an order for a diabetic diet, but the resident is not compliant with that diet, and frequently is eating candy and other restricted items on that diet, documentation becomes essential as a resource for determining whether staff members are aware of this dietary compliance concern and how they manage the situation and balance clinical priorities with observing residents' rights. Ideally, documentation would reflect that the staff had advised the resident on adverse complications associated with dietary noncompliance. If the resident knowingly chooses to continue a behavior that has potentially negative consequences, documentation should reflect ongoing attempts to educate and reverse the behavior, as well as the ongoing assessment of the resident's ability to understand and participate in the decision-making process. And let's move down to state licensure requirements. The scope and intensity of state long-term care licensure requirements vary. In some states, the need for specific documentation above and beyond the content of federal regulations is extensive, whereas in other states, the focus is less stringent. From a health information management standpoint, the long-term care facility must evaluate the documentation needs both from the perspectives of the state and federal requirements. If a facility is not certified for Medicare or Medicaid, state licensure requirements provide the regulatory structure for documentation standards. If, however, a facility is certified for Medicare or Medicaid, both the federal requirements and the state requirements must be met. All right, and our last section under regulatory issues is going to be the Joint Commission documentation, It's the Joint Commission long-term care accreditation requirements. So the emphasis on comprehensive assessments and care plans is reflected equally in the long-term care accreditation requirements of the Joint Commission. In many respects, Joint Commission long-term care requirements are similar to the federal long-term care requirements. The standards refer to the need for the facility to establish and follow specific care protocols depending on the scope and intensity of services provided in a given facility or unit. In addition to long-term care accreditation standards, the Joint Commission offers disease-specific care certification programs. For example, a long-term care facility with a special care unit for the care of Alzheimer's patients or Alzheimer's-type dementia patients could elect to seek certification for this unit with or without seeking accreditation for the entire facility. All right, so we're going to pick up with reimbursement and funding in our last lecture for this chapter. So for now, happy reading and happy studying.